Hello, I can't hear much. Just wondering if you can hear me.
I can. It's Francesca, but I wonder, are we on the right?
I think so. We probably are. Hi, Francesca. Nice to hear you. Well, I can see quite a few people on the.
Yes,
there.
We're on the right one.
Yeah.
I hope everyone.
There seem to be people on the right. I mean, I see Jim. Okay, maybe no, maybe people are coming.
Yeah, no, Jim will be speaking at the round table, I think. And so, no, well, there we are. It's just everyone was being very quiet.
Okay.
Excuse me, if there's anyone from the audience that should be in the main room as panelists, please let me know so I can upgrade you to panelists, just in case. Okay, so Emanuela.
I think Rupa Dot, is Rupa Dot in the room?
Okay, yes.
She is in the waiting room, and Jim Campbell as well.
Jim Campbell.
Rupa Dot is moderator,
Great.
so she needs to go first.
Perfect. She's here now. Do you know about Felicia Knau, Maria Espinosa, and Emanuela Posan? Because they seem to be raising their hands as well.
All of them need to be on speakers.
Okay, great.
I can see Jim.
Hi, Jim.
What about Alicia McCormick and Sky Collins?
I think Rup is speaking.
Hi, Felicia.
Yeah, Alicia should be on it as well as a panelist.
Okay, thank you.
Hi.
Great. Hi, everyone.
Hi.
We'll just give it about another just 2 minutes for logistics to make sure we have everybody here. Great.
Rupa, one question. I always pass my own slides, but Sky just told me that I wouldn't be able to do that.
We were worried about the tech side, so let me check here with tech right now if that would be possible. But as backup, I would have her just have it in case there's any issues.
Actually, it's actually too late now for me to project from here because I'd have to transfer them over.
Don't worry,
So
everyone will be able to project their slides if they want to. Everyone will be able to share screen if you're in the panelist side, in the main room. So don't worry about that.
The problem is I don't think I can anymore, but let me try.
Okay.
All right, Felicia, if not, Sky's here on backup and she can go ahead and do that too.
Yeah, no, it's just where the slides are right now. Let me try while you're getting ready.
Okay,
Sure.
Great, thanks.
Also, tech support, we need to get Francesca Colombo.
Francesca Colombo.
I'm here.
Oh, you're here, okay.
And then the minister.
Sandra Masai.
Okay, done. What about Leah Tadasi?
Leah Tadasi, yes.
Okay, good. They're all panelists now.
They're all panelists. Okay, that's everyone.
Great. And then we were going to have
you.
Sky as a panelist to share the screen for slides.
I think she's already Sky. Yeah.
Okay.
Can I ask everyone to change your names if you're still a speaker, please, just for us to recognize who's who.
Hello, colleagues. I'm just testing my
Not
mic.
sure I know how to do that.
Is it clear, or do I need to make some changes?
I can hear you clearly, but there is a buzzing sound. I don't know if that's the background or the mic.
Okay, maybe, I think I've signed in twice. Let me just check as a backup for my audio. So if they could also put the second one as speaker, that would help me deal with the audio problem.
Okay. It's done.
Hello, Rupa. I would ask anyone who is not taking the floor to please mute your microphones.
And I cannot change speaker to my name. Huh? It does not allow me.
Me neither.
Did I try sharing content? I actually have them up if you want me to. Sorry to interrupt, Francesca. Go ahead.
Yes, Felicia, go ahead and try that.
Does it work?
Yes, it's clear.
Perfect. Okay, so good. Sorry
And
about
no worries. Sky, do you want to also just do yours to just do a quick tech check and see if the slides are working as well?
Yes, I was just deleting the slides from my slide deck that Felicia will display. Let's go ahead and see.
So what, Sky, whatever is easiest, okay?
Are you all able to see now?
Yes, I can see it clearly. Thank you, Sky.
Perfect.
All right. So any other last minute tech checks, turning it back to tech, if there are any other, I know there were some issues with renaming speaker to the name of the speaker.
I cannot check the speaker, the remain speaker. There is no, I can change the name.
I can do it for you. If you tell me your name, I can rename you.
I'm Francesca Colombo.
Okay, just a minute.
And I have the same issue.
Yeah, don't worry, I'll do it for you. Just a second. Okay, Francesca, you're done. And what's your name? Sorry.
I am Stephanie.
Mm-hmm. Sorry, Stephanie.
Seydoux, that's SYDOUX.
Okay.
Okay, good luck, everyone.
All right, thank you. All right, I believe all the tech issues are addressed. And just turning it to tech, is it okay for us to go live now, or are we already live?
No, we won't manage the live streaming. You'll have to do it yourself, but it's okay to go live whenever you're okay to do so.
Okay, are we all good to go, everyone? All right, I believe I've met everybody before, but I'm Rupa. I'm going to be moderating today's session. So from tech support, if you could please convert us to live streaming now, that would be wonderful. And just a reminder to everyone, please mute yourself if you're not speaking. And tech, will you let us know once we're live?
I think you should be able to do that in the live streaming. It's the bottom next to interpretation. There's like a more bottom.
I don't have that option on my end. Does anybody else?
Oh, can I make you a co-host so you can do it? Is that
okay?
there now?
I'm seeing pause, stop recording. I don't have anything else here.
Okay.
In the Q&A, there's a note that it's live.
Okay.
Okay.
Hi, everyone. All right, wonderful. Well, we're going to get started. Foremost, I want to open this session and welcome all of you, excellencies, esteemed speakers and panelists, and everyone who has joined us today. Thank you for being with us in this historic first day of the Generation Equality Forum in Mexico. It's been an exciting morning kickoff in Mexico with a lot of momentum and really a call for transformative action to be driving the work ahead. What we'll be really focusing on our discussion is on economic justice and equality for women in health and social care, which, as all of you will hear, is part of the ambitious Gender Equal Health and Care Workforce Initiative that was launched earlier this year by the government of France, the World Health Organization, and Women in Global Health. I will be your moderator today. My name is Dr. Rupa Dutt, and I'm the Executive Director and co-founder of Women in Global Health. As we began today's discussion, it was in 1995, over 26 years ago, that governments noted at the 4th UN Conference for Women in Beijing that women contribute to development not only through remunerated work, but also a great deal of unremunerated work. And over the past 26 years later, as our expert speakers will outline today, this is still very much the case in health and social care. We know that health and social care is one of the largest and fastest growing employment sectors for women globally, and women comprise around 70% of the workforce. The COVID-19 pandemic has highlighted the extraordinary contributions made by health and care workers to health systems and health security. The contributions of women in the sector, however, have not been rewarded with economic justice or equality. It is estimated that around half the contribution of women to the sector is in the form of unpaid work and underpaid work. Large numbers of women are carrying essential health system roles at community levels in the pandemic, going door to door, contact tracing, disseminating information on infection control. And those women are either unpaid or working for low task-based stipends, which are not living wages. It is an uncomfortable reality that global health security rests on the unpaid and underpaid work of some of the world's poorest women. To hear about economic justice and equality and health and social care, I will now turn to our introductory speakers and then to our high-level panel who will guide us both through insights, causes, and solutions, as we really need political leadership to drive this change. Before going further, let me also remind all of you to please use the chat box, introduce yourself, use the Q&A section on the Zoom platform to submit questions to our panel. Please engage with us on social media as well. We're using the hashtag GenderEqualHCW, and we'll put that in the chat. And please engage with all of the organizations that are the host partners. We'll also include that in the chat. So on that note, I'm really delighted to welcome our partner who does not need an introduction to this initiative and to this platform is Ambassador Stephanie Sidou. She is the French ambassador for global health. And please, Stephanie, I invite you to the floor to introduce the Gender Equal Health and Care Workforce Initiative.
Many thanks indeed, Rupa. Such a pleasure to see you again. Dear honorable panelists and dear partners from the Gender Equal Health and Care Workforce Initiative, very good evening. It is such an honor for me to be here on the first day of the Mexico Generation Equality Forum. At last, after a year of postponement, well, it's finally started, and well, not in exactly the same format we would have expected, but a great show tonight of excellent speakers who will put this issue of justice right at the forefront of the agenda where it ought to be. France is a proud partner with WHO and Women in Global Health to support and lead the Gender Equal Health and Care Workforce Initiative, which was launched on February 25th. This global initiative aims to increase visibility, advocacy, dialogue, technical output, and commitment to action on improving gender equity in the health and care workforce, alongside the UN Women Generation Equality campaign, in order to accelerate gender equality actions and mark the 26th anniversary of the Beijing Declaration and Platform for Action. Today is our third event already, each one more inspiring than the other. Time after time, more governments, more international organizations are showing support to this initiative, and the mobilization picks up. And this dynamic, this momentum is the evidence of the importance of this agenda and of the need for action. So what are the objectives of the initiative? Well, they are to drive actions in the health and care sectors in 4 areas. The first is to increase the number of women in leadership positions. The second is to recognize the value of unpaid work and reduce the gender pay gaps. The The third is to protect health workers against violence and harassment. And the fourth, to guarantee safe and decent work conditions everywhere. And now what we want is to get as many commitments from multi-sectoral actors, states, international organizations, civil society, private sector, etc., in time for the Paris Generation Equality Forum and beyond, in order to achieve concrete progress in gender equality in the health and care sectors. Now, let me give you some examples of actions that could be put in place. For instance, ratification of ILO conventions, such as Convention number 190 on violence and harassment, Convention 100 on equal pay, and recommendation number 2004 on informal work. We can also ensure access to vaccine and PPEs to all health and care workers who need them. And there are indeed all other, many more types of actions which could refer to any of the 4 pillars I mentioned just now. So this is just the beginning of the global initiative, but the start has been very encouraging, as I was saying earlier, and the response we're getting gives evidence that this issue belongs high up on the agenda. Difficult to say whether COVID helped or didn't help. It didn't help us globally, but it definitely requires that we do give this subject as much attention as it deserves. Another point is that our approach stems from work which has already been evidenced, and the OECD, which will be represented today by Francesca, has played a great part in this, together with ILO and WHO. That is the concept of the triple dividend. The idea is that the health workforce is an investment, not a cost. And by improving gender equality in the health and care sectors, we bring benefits or dividends to 3 levels. A health dividend, since equal opportunities and decent work will attract and retain women working in health, helping to fill the 18 million global health workers shortages. Secondly, a gender equality dividend, as women gain more income and more decision-making power. And thirdly, economic growth dividend, as new jobs created in health will fuel economic growth and strengthen health systems and outcomes, all contributing to the achievement of universal health coverage and the sustainable development goals. And this approach is particularly relevant to today's session, which will focus on economic justice and equality for women in health and social care. Indeed, the health and social sector is one of the world's largest and fastest growing employer, with 234 million workers. Over the last 30 years, the share of female doctors has increased from 29% in 1990 to 46% in 2015. And this upward trend is expected to continue in the future as the proportion of female graduates continues to increase. We can only welcome it. However, there are still inequalities, and we know that female healthcare professionals face discrimination and pay gaps due to gender stereotypes and occupational segregation. In France, the net salary of women in public hospitals is 20% lower than that of men in average. And this gap reflects the different distribution of women and men according to job category, status, and branch of employment. The COVID pandemic has made the situation worse. The negative economic impacts have been particularly hard on women and girls who are generally earning less, saving less, holding insecure jobs, living close to poverty. This is, of course, very true for the health and care sectors. We need to strengthen the mobilization around the Generation Equality Forum. Our responsibility is to improve the work conditions of health workers now and ensure gender equality for future generations. France, as part of its feminist diplomacy, is and will be fully mobilized. I wish you a very successful roundtable. Thank you very much.
Thank you, Ambassador Sidhu. And it is really great to see the leadership that France is showing on gender equality. As earlier today, President Macron opened with saying women's rights are human rights and universal rights. We cannot stop fighting for these rights, and equality between men and women cannot be negotiated. We see that no country has achieved gender equality, and that applies very much to the health sector. You're calling for action, you're calling for really investments from all different actors, and really seeing this investment in the health and care workforce not as a cost, but a really one with a triple dividend return. Thank you, Ambassador Sidhu, for laying the foundation and bringing everyone up to speed on what this initiative is planning to do. On that note, I call on next Mr. Jim Campbell, who is the Director of Health Workforce at the World Health Organization. And Jim, I invite you to speak on the importance of health and care workers in economic justice and rights. The floor is yours.
Thank you very much, Dr. Dutt. Good afternoon, good evening, colleagues all over the world. To the Ambassador and to ministers and other distinguished panelists, indeed, the whole issue of economic justice, we saw at the weekend the agreed conclusions from, excuse me, from the Commission on the Status of Women, calling to accelerate actions. Now we kick off with the Generation Equality Forum, co-hosted by Mexico and France, which is an opportunity to really drive those actions further forward. What do we mean when we're talking about the opportunity to really look at equal access to resources and opportunities, decent work with fair wages and safe working conditions, and indeed the right to organize. We've seen in the last 12 months that labor disputes and protests have been reported in over 84 different jurisdictions. Rupert, you mentioned the conversations and the speeches this morning with President Macron and with President López Obrador. The UN Secretary General and others spoke about the major challenge of COVID-19, the seismic shocks that have reverberated around the world. We've seen the worst recession in over 90 years. We've seen the most vulnerable segments of societies disproportionately affected. And the statistics are quite shocking. Over 120 million people have fallen back into poverty. The ILO report that as many as 114 million jobs have been lost. And at the same time, the same time that we're calling for greater investment to respond to the pandemic, countries around the world have lost tax revenues, foreign direct investment, and trade and remittances have shrunk considerably. This, then many countries having to draw upon their economic reserves and indeed look to increase their sovereign debt to be able to invest into the response. The pandemic has truly, truly revealed a lack of resilience in many parts of our economies and societies. And partly because around the world there had been insufficient investment in health and social protection systems. When we're talking then about the economic justice and rights, we should also link to the dialogue that's ongoing, co-hosted by the governments of Jamaica and Canada on the financing for development in the era of COVID-19 and beyond. We're seeing clearly a consensus amongst the OECD, the G20, the G7, and many others the government should prioritize spending on social protection and health. We're calling, therefore, for some clear investments in health equity, in vaccine equity, and clearly in gender equity, which is at the heart of this partnership and this initiative. We have to invest in the people that provide these health and care systems around the world. And that means we have to invest in women. As you rightly and Ambassador Seydoux cited, the majority of the workforce around the world are women. Ambassador Seydoux mentioned the collaboration with France, OECD, the ILO and WHO on the High-Level Commission on Health, Employment and Economic Growth from 2016. That work resulted in 10 clear recommendations to the international community and to countries and their policy makers. And the second recommendation of those 10 was specifically on women's economic justice and rights, with a call to address the gender biases and inequities in the health and care sectors and to promote women's leadership. This is not a new agenda. This is something that the WHO, ILO, OECD, the government of France, and many others, and with the partnership of Women in Global Health, have been driving since 2016 and 2017. This is the opportunity, though, the moment that we can call for greater action, the commitments to act, as Ambassador Seydoux was encouraging us today. Sector Q, which is the human health and social care activities in the international classification of all jobs, is a leading source of jobs for women. It is a resilient labor market, and it has got increased demand for services worldwide. And we've seen that exponential demand for services with the COVID pandemic. But we must make jobs in this sector decent work. And we really must make sure that we're calling not just for more additional employment, but employment that meets the criteria of economic justice and rights, that meets the criteria for decent jobs. We have to address working conditions, the long hours, the burnout, the stress, the mental health of the workforce. We have to address pay. It has to be equal pay for equal work of equal value. It has to be fair pay. It has to make sure that we're not continuing to perpetuate the gender pay gap in this sector. We have to ensure the safety of all workers. And that includes addressing today that we ensure vaccine equity, that in all countries of the world, health and care workers are protected against the COVID-19 virus with the opportunity for a vaccine. But it also includes the safety around stigma and discrimination. It includes the safety around the protection from violence, harassment, sexual harassment, and any other form of violence in the workplace. We have to protect from informality. We do not want to see any of the Uberization of healthcare. We want to see decent work coming through. And we want to make sure that the disproportionate burden that falls upon women for unpaid care is recognized and addressed. These are elements which are part of the International Year of Health and Care Workers throughout the whole of 2021, where we're looking to drive the agenda to protect and invest in the health and care workforce together with governments, with partners, with civil society, with professional associations. And the Gender Equal Health and Care Workforce Initiative is a key part of the International Year It's a key part of the Generation Equality Forum. And WHO welcomes the partnership we see today with the government of France, with the government of Mexico, with our hosts, Women in Global Health, with all the other members of the panelists and distinguished speakers we have today. We look forward as WHO to working with you and to continuing this dialogue in the World Health Assembly in May, and to continuing this dialogue as we go to Paris. Thank you very much, Dr. Dutt.
Thank you, Jim. Really appreciate how you've outlined the interconnected agenda. It has been a seismic year, and it continues to be, with shock across the board. And what you've really described is, while we are having a conversation about economic justice, it's very much linked to a decent work agenda that is cuts across a variety of issues. And this is not a new agenda. These are not new asks, but really this is the time to take action, as there's consensus building around social protection and health, and investing in this as a priority on how we address the pandemic and build from the pandemic onward. On that note, I'd like to invite our final speaker in this introductory session of setting the scene. I'd like to invite Dr. Felicia Nall. She is the director of University of Miami's Institute for Advanced Study of the Americas, and the Presidenta Fundura of Tomachelo Pecho, AC Mexico. Please, the floor is yours, Dr. Felicia Nall, to present research on gender equity and pay in the health and social care workforce.
Thank you so much, Dr. Dutt, ministers and ambassadors who join us, friends. Es de verdad un placer estar con ustedes, pues desde la Florida, pero con mi corazón y mi alma en México, donde tengan todos ustedes su casa. Just saying that I am thrilled to be able to be a part of something in Mexico, the country that I call home, although speaking to you from Florida. I'm also thrilled to be able to share with you joint research that's been undertaken with the group, several based in Mexico, including Hector Ariola Ornelas and Beverly Esu, and to be part of the work of Women in Global Health also from their board. A great honor. Let me go ahead and start to share the screen. Rupa, you can see that okay?
Yes, it looks clear.
Terrific. Thank you so much. As I said, this is joint work led by myself, Beverly Esu, and Hector Ariola Ornelas on behalf of the Research Hub on Gender Equity in Health Systems and Caring Economies. We're going to share some data on the health and caregiving workforce, an array of inequities. And we're going to start from this point, which is what we were able to show in the Lancet Commission in 2015 on women and health, led by Drs. Langer and Millais, and from the Harvard T.H. Chan School of Public Health. We were able to show, and I was thrilled to be able to be a lead co-author on this, that women produce the majority of healthcare, both paid and unpaid, but in a context of adversity and discrimination. We've updated these data. We've been working on them. We were hoping, of course, like so many, to have much done in 2020, and we will be sharing them later on in 2021 through the Lancet. So I'll be sharing with you both some of the core data that was published with peer review, again, by the Lancet, which I think is so important in setting forth some of the data that so many have used. That was based on data from 5 anchor countries and 30 aggregate data countries. And now with our new data, we have 14 countries, you see the list there, and 49 aggregate data countries. So it's been a huge increase in the micro data that we can bring forward with the research I'll just begin to show you now. Let's start, however, with where we left off with the Lancet the Lancet Women in Health Commission in 2015. The data that have gone really around the world, $3.1 trillion is the base value of what women contribute, paid and unpaid, to the health sector. Those calculations showed about even between paid and unpaid. Putting that into context, it exceeds the total US and UK health budgets, 2.9 times the Mexican economy, 20% of the US economy. And the data that I think really brings out to me is that each and every woman, according to this, contributes $1,200 a year to health, but very few of those women actually get to reap $1,200 worth of healthcare for themselves or their family. Our new data, again, that we'll be sending to the Lancet soon, and hopefully we'll go through peer review and publication, includes now a solid estimate of discrimination. And that suggests that these are at least 2 to 3 percentage points higher, and a larger proportion is, in fact, unpaid, undervalued, unrecognized work. Now, globally, again, the 2015 data showed that when we divide the distribution of total hours paid and unpaid, women are contributing about 74% of unpaid hours and 55% of paid hours. And we can translate that into a value as a proportion of GDP. Unpaid, that's that 2.35% compared to just under 1% for men. And on the pay side, 2.47% of global GDP in that year compared to 1.24 for men. The new data based on 14 countries, and what I'm going to share with you are only really the basics. So we're going to look at a range. The country with the lowest value, the country with the highest value, and a weighted median over this sample of 14 countries. We're currently working on the projected global estimates that I hope we'll be able to share by the time we all get to Paris. So on the hour side, what we're seeing are similar results in terms of health-specific caregiving. So when you care for someone who's ill, the hours that women specifically invest, men as well, in caring for those who are sick. 68% of those hours of caregiving come from women. And if we include the health promoting domestic work, healthy meals, spending hours searching for firewood, it's 64% with a range between 57 and 82%. Overall, 63% is our median, and it ranges over these 14 countries between 59 and 77%. Now, how does that translate into value? On the health-specific caregiving side, 62% of the value is produced by women, and the health promoting domestic work, 58% by women, total 58% in the median on average across these, and that is without including the discrimination factor that we're going to be working into these analyses. I wanted to ground some of this in some more detailed and updated data on Mexico, given that we are virtually sitting in Mexico. So in the case of Mexico, in our 2015 data now and our updated data, we can look in detail at these health promoting domestic work hours. And when you add them all in, it's just overwhelming how the results change. So when you add that domestic labor, you're adding 27 hours to the 7 hours per week. And for men, which is important, 18 hours compared to their 4 hours from before. And on the value side, however, look at how this jumps. So it jumps to 12.9%, and for men to just under 10%. So women are still, without question, in the majority, and this again is before discrimination is considered in here, but the jump is huge, and in some of our countries, it's overwhelming. Close to 70, 80 or above of GDP. Now let's look at the paid side of the equation. And these are all the occupations that we consider health occupations, but also all of the people who work in health in other sectors of the economy. When we add that up over all of our micro data, we see that 75% of paid personnel in health are women. On the hour side, 72% are women. There's a much larger range in this. And that comes typically from particular countries like Pakistan, where there's a much lower female labor force participation rate, and it's actually decreased over time. When we look at the estimated value over the 14 countries, 63%, again, without the discrimination adjustment, is contributed by women in the paid part of the health sector. We're beginning to look at the discrimination gap. And this is an average over all the health occupations. Over the 14 countries we've analyzed to date, that ranges between 15% and 40%. And our anchor number for Mexico is just over 22%. These are, recall, the gross numbers in the sense that it's just the simple difference in average wages across men and women working in these occupations. But I wanted to delve quickly and in some degree of detail into what's happening in medicine, because I think it's a microcosm of something that many of us have said, and certainly this has been a leading lemma from women in global health, is that women produce the majority of health and healthcare and caregiving, but men seem to continue to have these leadership positions. So on the left-hand side, you're seeing data from the OECD, and I will let Francesca, of course, speak to anything to do with the OECD, but we've summarized a few bits and pieces here, which is the percent of all physicians between 1980 and 2018 over a select group of countries that are women. It's gone up over time in almost every country in the world. And in many countries, in the case of Canada, for example, the majority of medical students are women. That doesn't mean that the majority are doctors, however. We'll go back into that in just a second. And then when we look at leadership roles is where we really see this gap. 2 out of 17 deans of medicine, 6 out of 26 in the Canadian Medical Association board. But I want to take us back to Latin America. And for those of you who know Latin America, you will know that our national academies of medicine are especially important in taking a leadership role in academic medicine and also in policy. They've existed in some cases for hundreds of years across the region and now across the world. Take the case of Mexico, founded in 1864. The first woman was admitted in 1957. Proud to say I was admitted a few years ago, a great honor. Today, 15% of the 650 plus members are women, only 15%. And we just saw our first elected woman president of that esteemed association, Teresita Corona, who just finished and completed her 2-year term these past few months. When we looked at data across the region, my students and I, for a set of different national academies of medicine, you get the same story over and over. The best we could find was 20% in Bolivia, but it goes down to 4% in Argentina, 5% in Brazil. The vast majority of those who hold this kind of a seat, which is recognition and status, are still men.
And Felicia, just we're at the 1 minute mark.
Of course. And so on the medical employment side in Mexico, I wanted to share the good piece of news is that the under and unemployment, though, of women compared to men and physicians has actually gotten better over time. Men have basically flattened out, but women are now, we are very pleased with this, working more fully. And so we're seeing less under and unemployment in women. The last point and the conclusion. So when we think about women economics, are we just talking common sense? Overall, and as a labor force economist, we say women account for approximately 40% of the world's workforce. The labor force participation rate of 53%, it's well below that of men at 80%. There's a McKinsey study that many of you know that says that if female labor force participation were to get up to that of men, women would contribute an additional $28 trillion or 26% of global GDP. I say that's common sense because it's obvious that we need to solve this problem. Women are the motors of economic growth. They produce the majority of healthcare paid and unpaid, and they subsidize our economies. Yet health systems are disabling instead of enabling to women, and this is even pre-COVID. Now we have this amazing opportunity, I think, if we can turn it around, to be able to harness these flexible workspaces so that men and women can have an equal opportunity to both contribute to their families and be part of the labor force. And we can start by looking at this in the health sector. There are 3 steps. We need to count all of the hours and all of the people who are contributing by gender. We need to appropriately value their work, including discrimination. And we need to invest in exactly what Jim was saying, a fair and decent workspace in which they can make full use of their education and their potential for the betterment of all. Thanks very much.
Thank you, Felicia. That was a really informative, detailed presentation, technically grounding us in the realities and those numbers, showing how much of GDP we're losing when we're not operating in an economic just manner. Your closing message to create enabling environments, really making sure we count, value, and invest is quite clear. On that note, I'd like to now transition to the second part of the program and invite our panelists, which are joining us from all around the world. Really appreciate people joining late nights, and for some it's still mid-afternoon. So this part of the portion of the program is we really want to bring the perspectives of governments, multilateral organizations, civil society, unions, all together to really look at how do we achieve this economic justice pathway, particularly for women in the health and care workforce. I'd like to first invite Honorable Dr. Leah Tadessa. She is the Minister of Health in Ethiopia. And particularly Ethiopia is known to be a country that has been able to really formalize the health workers, which are the least formalized, the community health workers. And Ethiopia, Dr. Tadessa, has around 40,000 female health extension workers who have been at the heart of the response to the COVID-19 pandemic. Could you tell us a bit more about the decision to integrate these health workers, majority of them which are women, into the formal health system as paid employees and the impact that this has had? The floor is yours.
Thank you very much, Rupa. And it's a pleasure to join this forum addressing this key issue of gender equality in the health and care workforce. So yes, health extension program is one of Ethiopia's flagship programs, which has dated maybe around 17 years now. And especially the late 90s, when the majority of cause of days and morbidity and mortality has been very high rates of infectious diseases, maternal and child health issues, with a big rural community, and we had, of course, a very limited health workforce in terms of physicians and nurses. This program came into picture. Of course, we had a community health worker program before that, but it was not a formal health workforce. So it was started as a pilot in one of the regions, and with the impact it had, the idea was to really invest in a community health program with almost all women being trained for each village, so that they can give health promotion and disease prevention, as well as basic curative services very close to the community in health posts or health clinics, but also in house-to-house visits. And it was intentionally, they were made women because this is most of the services were given at households, and in the households, in the families, women are the ones caring for their families, mostly leading the health conditions of their families. And also, it made them connect with them, as well as it was, of course, culturally acceptable and also seen as an opportunity to empower more women into the health workforce. And once the program started with a one-year training after a high school graduation of these health workers, they were being deployed. So it started with around 30,000, and then now we have around 40,000 across the nation giving those basic services. And in the past 15 years, huge impact in terms of reducing maternal mortality, access to reproductive health services, reducing child mortality. It has been achieved, and a majority of this achievement has been really related to this health extension program. And these health workers, since the beginning of fully establishing this program, they were made part of the civil servant, the regular health workforce with regular salaries. And I believe this was one of the key decisions the government made that was really instrumental for the success of the program, because it was really instrumental to make it sustainable, to ensure the health extension workers stayed within the workforce. They were recruited within their village, their own village, which also had its own incentives to retain. But of course, in due course, we had to look at ways to more incentivize and keep them in the workforce as with career development. So initially it started with a level 3 training. Now we are also training them as level 4, and also created some opportunities for them to also proceed into nursing programs for few of them. although majority of them still are are working as health extension workers. Very few of them transitioning into some leadership roles in their district health offices as well. So it was really an instrumental program, but again, the key aspect of the success was really making them part of the regular workforce in terms of retaining and bringing this huge impact.
Thank you, Minister Tedesse. And just as you are sharing the story of Ethiopia, it's quite clear that, that your government is still seeing this as an investment that is not a cost, but an investment that is leading to better health and well-being for all, especially making progress on maternal neonatal care aspects of it. And especially during this time, the COVID-19 pandemic has challenged all governments and all people. And as going back to some of the points that Mr. Jim Campbell talked about, how with limited financial flows, how is the government of Ethiopia looking at its investment in these extension workers? Can we expect this program to continue to grow and receive its investments in these challenging times and beyond? And how do you have that political commitment if that's the case?
Absolutely. Within this pandemic, in the past 1 year, the health extension workers had their own instrumental role in the response. We used house-to-house surveillance at some point to basically for two main purposes. One was for the COVID pandemic itself, to teach the community and also detect any cases that were in households of the COVID with COVID symptoms, but more importantly, teach the community, create awareness. But at the same time, continuity of essential services during the pandemic was a critical issue, and we had to prioritize especially key services like maternal reproductive health, child health services, and other chronic illnesses like HIV, TB, and some NCDs. So they were also, during those surveillance house-to-house visits, they were detecting such cases and ensuring linkage to health facilities. So their role was really, not just was, but is still instrumental in both the response to the pandemic, but in ensuring the continuity of essential services. And actually, this year was a year where we have launched our 10-year national strategy development plan, as well as for the health sector specific 5-year strategy, which also led us into revisiting and relooking at our health extension program. We had actually done a 1-year national assessment a year ago as well, just before COVID pandemic started, of the health extension program. And now we know its impact is huge and the need is still relevant, but there are also areas that need improvement. So we have now designed a 15-year roadmap to optimize the health extension program, still make it more stronger in some areas, meeting the needs of both the workers, but also the community, because of the changing needs, growing needs of the community, and also addressing public health emergencies like what we are now. So the commitment is still there, the political commitment to continue the investment. But of course, we still have many challenges in terms of gender and health workforce as we look into the health, as was being stated earlier, where still a large number of our health workforce, including health extension workers, are women, but still we have very, very few women in the health workforce in taking leadership roles, which is also another area of political commitment to improve in the way forward.
Great. Thank you, Minister Tedesse. And it's great to hear that there's at least a 15-year roadmap and political commitment behind that, and that you're looking at gender equity, both linked to having community health workers in the formal workforce, having upskilling and training, and also investing into looking at the leadership roles. On that note, I'd like to turn next to Miss Maria Espinoza. She's a former president of the UN General Assembly, has been a minister in Ecuador as well. And Maria, just, it's so wonderful to have you join us. You have walked that walk with really getting political commitment in the Universal Health Coverage Declaration just before the pandemic. And really, this particular, the 2019 political declaration on universal health coverage specifically commits to eliminating unequal remuneration for women in the health workforce, supporting earlier commitments made for all sectors in the Beijing Platform for Action and SDG 8. How can we mobilize at political level to turn these commitments into real money for unpaid and underpaid female health and care workers? What will it really take? And especially you also are sitting and being able to provide a bird's eye view as you're participating in the Generation Equality Forum Steering Committee. You're part of a commission looking at COVID-19 response. As you're seeing all of these conversations take place, what opportunities are you really seeing to advance this agenda?
Well, first of all, thank you so much, dear Rupa, for this invitation. And of course, we wouldn't be here if it wasn't because of the leadership of the government of France, of the World Health Organization, and the Women in Global Health for bringing us together, organizing this much needed conversation. And you said it very well. And let's start perhaps by recalling a major milestone in 2019 with the adoption of the most ambitious and comprehensive political declarations on health in history. And that is the political declaration on universal health coverage. So faced by the COVID-19 crisis, it is crucial that leaders consider seriously this inextricable link between universal health coverage and health emergencies and uphold their UHC commitments. I think that to build back better, to deliver health for all, makes the case for why we must invest in strong and resilient health systems that can, of course, be ready to respond to disease outbreaks while continue to deliver critical routine services. And evidence shows, we have heard during this conversation, that in times of crises, the needs and rights of women and girls are often neglected, including gender-based inequalities in the health and care workforce. So in order to address these inequalities, I think it is a moral imperative for women should receive the same salary for the same work. We heard, scaring numbers from Dr. Knoll at the beginning. Women should enjoy adequate working conditions, safety and social protections, and also equal opportunities to be in leadership positions in the health sector. Addressing the discrimination of women in the health and care sectors, I think have also become a strategic imperative, especially in the context of the COVID-19 pandemic. We have seen time and again, women leading the way in finding sustainable solutions, enhancing solidarity, and making their communities, their cities more resilient to the crisis. So we have, heard so many times, and from Ambassador Seydoux so clearly, women earn less, have less access to education, are overrepresented in underpaid or unpaid jobs. Therefore, I think that their capacity to absorb economic shocks is less than of men, and we should take that, of course, into consideration. We have to also consider that mainstream economics have mostly ignored the social and economic value of reproductive labor, which is so critical. The work of maintaining a home and caring for children and the elderly still falls disproportionately to women and enjoys neither social nor economic recognition, as we have heard this afternoon. And, numbers, and we have heard so many numbers, but perhaps, just to quote one that is really staggering, the value of unpaid care work amounts globally to almost $11 trillion per year. That is a huge amount. So we all know that the COVID pandemic has touched and affected disproportionately women and girls. it is a paradox that according to a study conducted by BMG Global Health, they state that 85% of COVID-19 decision-making and advisory bodies globally are held by men. And it is clear, you know, there that it's still there is still a long way to go before achieving a gender equality in the health sector. What is the way forward? I see with great hope, I have to say, the forward-looking and ambitious initiative on gender equal health and care workforce, more women in leadership role in the health sector, equal pay and value care work, safe working environments free of violence and harassment for women health workers, decent working conditions for them. We cannot ask for a better formula, this triple dividend that we heard at the beginning. And I would like to close, Rupa, with 4 asks. First of all, a call to leaders worldwide to comply with their commitments on universal health coverage and the political declaration, especially on provisions pertaining gender equality, on equal pay and safe and enabling working environments and social protection for women. For this to happen, of course, it is imperative that we connect the scales, multilateral international agreements with national laws, regulations, and proper policies in place. The number 2 is to ensure that the trillions of COVID recovery packages seriously consider investment in women and girls, from closing the gender digital gap to ensuring fully funded shelters and infrastructure for victims of violence. The number 3 is ensure serious and sustained investment in the care economy as part of vital social infrastructure. The care economy, I always say that, is the economy of the future in terms of job creation, in terms of defeminizing care work and strengthening social cohesion. And the number 4 to close is to ensure that legislation, policy, and norms at the national level boost women's meaningful participation in health-related decision-making. And this is not only about numbers, it is about quality, it is about wisdom, it is about the contributions that as women we make to the economy, to social cohesion, and to this new social contract between society, the economy, nature, and politics that we are now talking about in terms of building forward better after COVID. So very much looking forward to see this initiative in full speed in Paris, and thank you for this opportunity. Back to you, Rupa.
Thank you, Maria, and thank you for your leadership and your clear messages on the way forward and how to do it, and really using and leveraging the political commitments already made on the Universal Health Coverage Declaration, but also looking at the COVID-19 packages around the world as another opportunity and seeing it again, the messages echoing itself that this is an interconnected agenda. We cannot talk about decent jobs without also making sure there's women's equal participation in leadership and health. On that note, I'd like to invite our next speaker, Ms. Francesca Colombo. She's the head of the Health Division of the OECD, and particularly OECD is one of the drivers of EPIC, the Equal Pay and International Coalition. Francesca, we've heard so much about driving this equal pay agenda already in today's conversation, but also having much more equitable pay and closing the unpaid, the underpaid, the informal. What lessons has the coalition generated that could be applied to the health and care sector?
Thank you, Robert. Thank you so much for the opportunity to speak, and thank you for the wonderful presentations by Felicia, Jim, Stephanie, really for setting the scene. What is the EPIC? First of all, it's an equal pay international coalition. It's an initiative that OECD has been advancing together with UN Women and ILO. So it's really part of a joint commitment to advancing really the issues of equal pay. And the idea is very much to build evidence on the pay gap and also on the type of policies that can help to address it. I think this links very much to important sustainable development goals, in particular 2 of the goals. One is, has been very much mentioned today, the issues of equal pay for work of equal value. And I think the notion of value is one which is particularly relevant in the context of healthcare. And the second one really has to do with the issues of gender equality and women empowerment. So what could be some of the learning from this initiative for the issues of equal pay, but also gender equality in the context of the health and social care sectors, where we heard so much of the inequalities that exist and differences in pay, and I think Felicia has already highlighted. There are probably 3 lessons that I would like to draw the attention. The first one is obviously the critical importance of pay transparency. Despite the fact that we start having some evidence, there is still very much of transparency in the differences in the pay level for equal type of work. And I think this is quite instrumental really to support the strengthening the evidence for policy action. We had an event on the occasion of International Women's Day at the OECD that really said that was titled "Show Me the Money." And it really showed how over time, by showing these differences in pay, there has been some progress, not enough, but there's been some progress. For example, the gender pay gap among the full-time employees, that's not just in the health sector, but for the economy as a whole, is still 13%, but it stood at even 5 percentage points higher just a few years ago. So showing the pay difference, having that transparency, it's a way to start to address the issue. But I think the second message, which from my perspective is important to get to, is that transparency in pay, understanding who is getting what, is only one part of the equation. And while we do know that pay differences exist, including in the care sector for the elderly, which is predominantly a women job, and still there are differences in the pay. I think the critical issue is that we need to look at equal pay for equal value, and the question of the value really that these jobs, which are overwhelmingly occupied by women, it's clearly something that needs to be addressed if we want to make progress in terms of that inequalities. And women are overrepresented in jobs that do pay less, even within the sector, the long-term care sectors, care for the elderly, of course, nurses as well. That's overwhelmingly a women job. And I think we need to, in a way, in a context also of speaking about the COVID-19 and in Paris, where I live, during the first wave of the pandemic, people used to clap, going out, every evening at 8 o'clock and clap for the nurses, clap for the workers, the doctors, the roots, pay, in some cases even with their life or with their mental and physical health, just to care for people who had COVID-19. But I think if we want to be serious really about the issues, we need to go beyond applause. That's something that we are, trying to take forward at the OECD, with a job really looking at better pay, better working conditions, but especially the societal recognitions for care and also social services work. And I think that needs to go beyond, as I mentioned, pay, and look at the whole issue of job quality in a more comprehensive way. So earnings quality, for example, is not just an issue of differences in level of earnings, but also are earnings enough to really enable a worker to contribute to their well-being? Are these average workings enough in terms of level? What is their distributions across the health workforce between those who work in the health sector and those who work in other sectors? So that's a particularly important issue, that earning quality is not just a matter of earnings, but also the quality of those earnings. I think there are issues, obviously, which are clearly important to look at, which have to do with labor market security. So the aspects of economic security, related to the risk of job loss. What are the conditions when there is a job lost? What are the risks of unemployment? What are the type of benefits and so forth? This needs to be part of the equation, and particularly in the care sectors for people, for older workers. That notion of labor market security is something which is very much lagging behind. And the third one is the issue of quality of the working environment. So, yes, we need to look at the pay, but it's fundamental to go beyond the pay and really look at the quality of the job and the value of those positions. And the third lessons, which I think is important to look at, is that if we want to really address or have the full picture and address the issues, we need also to look at the notions of more broadly social institutions, so representations in decision-making positions. I mentioned the issues of pay and unpaid jobs, the career progression, and so forth. And so really try to understand how we can couple the pay transparency with issues related to discriminations in social institutions, family policies, which might make a difference for a person working in the care sector, and in addition having, for example, to have responsibility as a mother or as a member of the family. We know that the distribution of unpaid work is very much uneven, with women having between 2 and 10 times more often responsibilities for caring for children, caring for elderly, but also for things like cooking, cleaning, and so forth. So I think it's only by addressing those broader social institutions which are inherent in family policies more broadly that we can address and make a difference. I think there is an opportunity perhaps to conclude. The opportunity is that in the context of COVID-19, there is huge amount of discussions and say about what do we do about recovery packages. And the opportunity and the challenge perhaps is really to make sure that the discussions about equality, gender equality in health, in jobs, in pay, and so forth, become critical part of that recovery agenda. I mean, the reasons, economic as well, are really quite well known. I mean, it's a matter of investing in the human capital and not wasting human capital or wasting talents, which is a very strong determinant for really addressing the inequalities that exist between women when in the health and long-term care sectors. So it's not just a matter of justice, but it's really a matter also of economic developments and avoiding waste in talents. And I'm stopping there for the moment, Ruta.
Yeah. Thank you, Francesca. And you've really covered a breadth there. And to hear that this is not only, about from the right thing to do, but it's also very much the smart thing to do. There is economic evidence backing it, and not to waste human capital, and look at it from a very holistic approach. So really valuable lessons coming out from the Equal Pay International Coalition. I'd like to turn next to Ms. Sandra Masai. She's the Sub-Regional Secretary for the Caribbean. Sandra, great. Just want to make sure we have you on video there. She is the Sub-Regional Secretary for the Caribbean from the Public Services International, also known as PSI Union. Particularly Public Services International has just issued a manifesto titled Rebuilding the Social Organization of Care, which argues that the current social organization of care is unbalanced, unequal, unsustainable, all themes we've been hearing today, with the majority of the care falling on women. How does this impact on women in the health and care workforce, and what can be done? We'd like to hear about this manifesto and where we're headed with this. So Sandra, the floor is yours.
Great, thank you, Rupa, and hello to all my colleague panelists, as well as also to the colleagues and friends who are online and listening to us. To be quite blunt, the impact on women, and particularly women in the health and care workforce, is that, quite frankly, they're overworked and underpaid. They're exhausted. They not only have to be working obviously in the various workplaces, but they're also working at home. So there's sometimes a double or even a triple set of work that they're doing. They're tired, they're exhausted, they're ill. And unfortunately, particularly in the case of COVID-19 and dealing with COVID-19, some have died. The latest estimates that we have are that about 17,000 healthcare workers have passed as a result of their work in the sector and contracting the illness. But let me get more into what can be done, because I think that this is where we have to focus and where we have to put all of our efforts, all members of society. First of all, within PSI, we're promoting that it is indeed better wages and working conditions for women workers who are in the care sector that will enable their full participation in society, in all spheres of society. And it's also important for us to view care as a human right. We're not only talking about the value of care in terms of money, we're talking about the value of care in terms of the fact that it is a human right and that we need to invest in it. So in terms of our manifesto from Public Services International, we've identified what we call the 5 R's. That is that we need to recognize the social and economic value of care work, whether it's paid or unpaid, as well as the human right to care. We also talk about rewarding and remunerating that care work. We also want to reduce the amount of care work that women do and make sure that there's a more spread between those in society and with those in the home. We also want to ensure that when we're talking about care, that in terms of reward and in terms of redistributing the care work, that we look at the sexual division of labor and eliminate that sexual division of labor. We want to reduce the burden of uncared work on women, and we also want to reclaim the public nature of care. That is, that the state has a responsibility and restore that duty and responsibility of the state in providing care and care services where there are none or where they are very limited. In other words, invested in care. So if I may, in terms of looking at what we are talking about needs to be done, let's talk more about recognizing the social and economic value of care and seeing it as a human right. And we're talking about the full spectrum of care. We're talking about childcare, patient care, care of those persons with disabilities, care for the elderly, care for children at school, people in hospitals, care in institutions, in offices, and in all spheres. And it means that a lot of these, we have to also recognize and admit that many of us took these type of care roles for granted. COVID-19 has brought it more to the fore, but let us not forget that there are other illnesses and diseases still in our societies. There's still outbreaks of dengue fever. There's still the issue of non-communicable diseases. There's still chronic illnesses that people still have to receive care for. And what is happening in the case of COVID-19 pandemic is that our healthcare workers, those within formal institutions and those who are in the informal settings, also have to deal with those cases. But I think we do see some recognition by some of us in society that care has a value, but I'm not so sure that we're recognizing it as a human right. And whenever the word value is used, people are tending to put a money value to it. It goes beyond money. It's not really about money alone. It's really about the human right to care. When that care work is done by people in the family or through volunteers or through staff, it means that other members of the family have opportunities to go out to work, to even rest and relax. So someone else is providing that opportunity for others to do what they want to do. In terms of the communicable diseases, we're seeing increasingly a number of communicable diseases raising their heads and becoming worse because those, the opportunities for people to either receive the care that they need to fight those diseases would be lost because of lockdown measures. And we've had many stories of our members across the world having to fight in order to give that care to the people that need it. And therefore, in the design of the kind of measures that are being taken, that factor is not being taken into consideration. And it's limited in many instances to care in institutions or in the isolation facilities or in the quarantine institutions, and not considering that other type of care that is critical.
Thank
if I
you,
can go to the
Yeah, we're at time, so just your very last 30 seconds, and then we have to transition. They're going to close the platform on us, so thank you. Really powerful message there about valuing care and the care that we don't expect and how it frees up time for others. So Sandra, your closing message here.
Well, my closing message refers to rewarding and remunerating the care work, and that a lot of countries have to now look at how do they find the fiscal space in order to do that. And that is particularly tied to our work in PSI related to tax justice and looking at the progressive taxation policies that need to be in place, that need to be looked at very carefully and reviewed to ensure that the multinational corporations who are not paying their fair share will pay their fair share, and that fair share then can be to the benefit of the sustainable development goals that we all have, and ensuring that the investment in social care and in healthcare and indeed the wide swath of public services is put in place so that we can have the kind of communities we want, the kind of societies we want, and the gender equal world that we're all aiming for.
Thank you, Sandra.
Thank you very much. Over to you, Rupa.
Great, thank you. That was wonderful. Very concrete suggestion. I'd like to invite next Ms. Leisha McCormick. She is the CEO of Last Mile Health. Leisha, really the question to you is, we know the issues, and we know how extensive the issues are of women's unpaid care work, unpaid work in the health sector. What arguments and evidence would you use to mobilize political support for integrating them into the formal sector payroll, particularly pulling from Last Mile Health example?
Thank you so much, Rupa. And thank you to the government of France, government of Mexico, World Health Organization, and Women in Global Health for convening this really important discussion. I'm grateful to be here at the Generation Equality Forum with this esteemed group of panelists, including Her Excellency, Dr. Leah Tadase, who's been a real champion of community health workers and whom Last Mile Health is honored to work with to support Ethiopia's community health program. We're here today because we're motivated by an injustice. Women account for 70% of the health workforce, and yet they subsidize the global economy by over $1.5 trillion in their unpaid work. Dr. Nall just offered, I think, some staggering statistics and some really great data and evidence. And I think while we can see that some of her figures are harrowing, they also offer avenues for some great hope and opportunity. These community health workers who have really been at the front lines of the COVID-19 response for over a year have been the ones who've educated communities, who've detected cases, and in many places, they've kept essential health services going. We applaud community health workers as heroes, but as my colleagues on this panel have referenced, applause is not enough. We need to invest in them as professionals, and the legacy of the COVID-19 pandemic can be health for all, but only if we invest in paid community health workers worldwide. This investment includes integrating community health workers into the formal payroll, which is essential for 3 reasons. First, paid community health workers are vital to improve health outcomes. Pay was identified by the World Health Organization as one of the key drivers of a successful community health worker program. And these programs are proven to equitably and efficiently deliver essential primary health care, which is critical for universal health coverage. One example that I would reference is the government of Liberia's Community Health Assistant Program. After the Ebola outbreak, so shocking relevance in terms of epidemic and pandemic prevention, the government of Liberia deployed over 4,000 paid community health workers to not only deliver primary health care, but also to conduct active community-based disease surveillance. Now and today, these community health workers have conducted 3 million patient visits and treated over 1 million cases of childhood illness, services that have continued during the current COVID pandemic. Second, paid community health workers have a high return on investment. The critique of integrating community health workers into the formal payroll is that they will be too expensive or unsustainable. But as Ambassador Seydu has shared, health workers are an investment and a benefit, not a cost. The $6.5 billion in US dollars that's needed per year for greater global health security is less than 5%. I'm sorry, forgive me, 0.5% of the total economic cost of the COVID-19 pandemic. And in addition, for every $1 a country invests in community health workers, $10 is returned to society due to increased productivity from a healthier population, reducing the risks of epidemics, and the economic impact of increased employment. It turns out that what is really unsustainable is the repeated health and economic trauma of outbreak after outbreak. Third, paid community health workers are vital to ending the current pandemic. The pandemic will not be over anywhere until it's over everywhere, and this requires the largest vaccination effort in history. Today, only 1% of administered COVID-19 vaccines have gone to people in low-income countries, and at this pace, the pandemic could continue for years, unless we invest in community health workers now. Our colleagues at KLR have estimated that for every $1 invested in vaccine doses, we must invest $5 in delivering the vaccine. That includes funding and supporting health workers who administer vaccines, running education campaigns, connecting communities to health services, and building the trust required for patients to get vaccines. And lastly, we need to work together to ensure that when community health workers are paid, women are not pushed out of this vital workforce. We know that gender equity in community health results in better health outcomes and has the potential to lift hundreds of thousands of women out of poverty. Paying health workers and promoting female health workers should not be mutually exclusive, but really it rather has to go hand in hand.
Great. Thank you, Alicia, for all those really key examples that you have used in the work that you are doing in Liberia and many other countries, and especially that last point that we can't compensate community health workers in a gender blind way. We have to be very aware of the gender dimensions and being gender transformative and keeping women in the workforce. I'd like to turn last but not least to invite Miss Emanuela Pauzon. She is the Senior Specialist of Gender Equality at the International Labor Organization, and really as we come to the end of this session here, we know that this is not a new challenge. The ILO Convention 100 on equal remuneration dates back to 1951. It's 40 years old. So the gender inequities we're discussing today are not new. What can we do to ensure that women in health and social care workers do not have to wait another 40 years before they are fairly and equally paid? Emanuela, the floor is yours.
Thank you, Ropa, and good evening to all of you. So from my side, since a lot has already been said about the health sector, I would like to put the topic of equal pay for work of equal value in a global context. And we have mentioned already the importance of a legal framework to fight the gender wage gap. It's true, it's taken a very long time because the principle of equal pay for work of equal value has been there for a long time. And in a way, maybe we need to say that COVID is helping to revitalize, to revive this whole issue of equal pay for work of equal value, because it is true that during the past years, and in particular the last year, we have seen some more interest on this topic. So on the bad side of the story, there is the fact that globally we still have countries that do not have any form of legal protection in their legal framework to fight the gender wage gap. So this is not a good news. And we also have a lot of countries that still have legislation that exclude certain categories of workers, in particular agricultural workers, domestic workers. And this is also not not good, because it means that a large number of female workers are not entitled to the right of equal pay for work of equal value. On the other side of the story, we also have some good news, because we are seeing some positive trends towards legislation that prohibits the pay discrimination, but not just on the ground of sex and gender. Now we are also seeing that the pay legislation vis-a-vis race, ethnicity, nationality, skin color, marital status, language, religion, etc. So there is a trend that is moving in the right direction. We have recent legislation in Georgia, Bahrain, Antigua and Barbuda that do add an element of intersectionality. There are also currently a number of reforms ongoing in countries like Afghanistan, Sudan, Suriname, and Tonga, and all this new legislation and reforms are taken into consideration to include the concept of equal pay for work of equal value. We have seen Mexico a couple of weeks ago passing a piece of legislation on equal pay for work of equal value, and the European Commission that has put forward a proposal for a directive on pay transparency policies, while we have approximately 13 countries that are moving towards, that already have, transparency policies. So we know that legislation is not enough and that much, much more is needed. First and foremost, we do need to work a lot on vertical and horizontal segregation in the labor market. Because when we say that we need to create jobs, these jobs have to be for everybody. There should not be jobs for women and jobs for men. We also need, as it has already been seen, to have more women in managerial and leadership positions. And all of this comes with concerted efforts. We need to close the gender digital divide, of course, have more women in STEM, but bottom line, we need a workplace that works for women and also for men. When we improve working conditions in a sector, men will also start to join that sector. And that's when we need to make sure that the usual stereotypes and segregation that is not perpetuated. We need to insist on systematically applying gender-neutral job evaluations and tackling direct and indirect discrimination. And as it has already been said, we certainly need to address the big elephant in the room, which is addressing unpaid, redistributing unpaid care work. This is certainly of big importance. And we do know that there is a correlation between collective bargaining and unionization of workers, and there's a positive correlation there between social dialogue and pay equity. Before you asked about EPIC, the Equal Pay International Coalition, this last year, since COVID started, many more countries have joined EPIC. The last two are Costa Rica and Luxembourg. And there has been a lot of exchanges between countries asking each other, how are you handling this? What tool are you using? The private sector as well is very well engaged. Universities are trying to better understand how they can work on equal pay for work of equal value within their sector, because also the university sector, professors, the education sector in general is another sector that has a very high segregation and imbalances in equal pay. So I know you're pressed with time, so I'll stop there. But I do hope that you will take a look at the Equal Pay International Coalition webpage, and perhaps you will be able to join in the near future.
Yeah, Emanuela, thank you for these last remarks here, because they're on a very positive note to hear that there is a growing political momentum, and particularly seeing the legislative change, the exchange that's happening, and your invitation to go to EPIC to learn about how to address the equal pay aspect of things as well. I know that we're right at the minute, and as much as I would love to come back to all of our panelists to really weigh in, I think the message here is clear. We are very delighted to have the Gender Equal Health and Care Workforce Initiative, because this is the time to have a new social contract. We know that COVID-19 has been a major health, social, economic, and political shock for all, especially for women. We need radical thinking, and we need to think about how we value value and how we build systems for future global health security that are much more gender equal and much more gender transformative. And today's speakers, our opening session, as well as our panelists, have really made a case for all of us to continue this momentum as we go to Generation Equality Forum France, to drive this commitment, to drive action, to drive investment. Thank you everyone for joining in today, and thank you to our hosts, the Government of Mexico and Government of France, and to our partner World Health Organization for bringing this event together. Everyone have a wonderful rest of your evening, day, or morning. Bye-bye.
Bye.
Bye, thank you.
You all.
Bye-bye.